Hello everyone and welcome to our module on osteoporosis. Osteoporosis gets its name because in this disorder bone becomes porous, especially the trabecular bone. So at the bottom left side of the screen is the normal appearance of trabecular bone, and on the right is the appearance in osteoporosis. You can see that the bone is thinned and the pores between bones are much bigger. When this happens, the bones become weak and they're prone to fractures, and there are no clinical symptoms of osteoporosis until a fracture occurs. The major problem here is that bones are prone to fracture and fractures occur easily. Let me mention some terminology around osteoporosis that is important. Osteopenia means a decreased bone mass. Osteoporosis refers to a markedly decreased bone mass, and later we'll talk about the exact cutoffs for osteopenia and osteoporosis based on testing results. And the reason osteoporosis is distinguished from osteopenia is because once patients cross over into the osteoporosis range of low bone mass, there is a significantly increased risk of fracture. Osteoporosis affects trabecular bone more than cortical bone. If you look at this drawing at the bottom of the screen, trabecular bone is the spongy bone found at the ends of long bones. Cortical bone is the hard bone that surrounds long bone. And trabecular bone is trabeculated, meaning it's honeycombed, and therefore there's lots of bone surface area. And osteoblasts and osteoclasts are found on the surface of bone, so there's lots of surface area for them to reside in the trabecular bone. And when osteoporosis develops from too much bone breakdown, it therefore affects the trabecular bone more. So what are some bones with a high trabecular bone content? Well, there's lots of it in the spine, and this is where lots of fractures occur in osteoporosis. There's also lots of it at the head of the femur near the hip, shown in this x-ray here, and that's where a lot of fractures occur in osteoporosis. You can also find trabecular bone in the wrist and the distal radius, and this is also where lots of fractures occur in osteoporosis. Osteoporosis is common in elderly white women, and I've put a picture of my grandmother on the screen here to remind you of the classic demographic of the type of patient who develops osteoporosis. So why is osteoporosis more common among elderly white women? Well, in order to answer this question, we have to talk about bone mass. So your total bone mass in your body is not constant throughout your life. It changes over time. And your peak bone mass occurs in young adulthood. So your bone mass increases during childhood and it peaks in young adulthood. And the peak depends on many things. It depends on your gender, whether you're male or female, your family genetics, and also the amount of calcium and vitamin D and other things you consume in your diet. So if you look at this picture at the bottom of the screen, this shows age in years along the x-axis and bone mass along the y-axis. And you can see that it rises and peaks in early adulthood at about 20 to 40 years of age. It then decreases slowly thereafter. Each resorption formation cycle of the bone leads to some bone loss. Now, if you look at this graph on the screen, two important things are shown. First of all, males achieve a higher peak bone mass than females. That's why osteoporosis is more common in females. In addition, when females undergo menopause and lose estrogen from the ovaries, their rate of bone loss is accelerated. So this is why elderly females are the most common demographic to develop osteoporosis. They have a lower peak bone mass and they have accelerated bone loss after menopause. So some key points about bone loss are shown on this slide. As we saw on the graph on the previous slide, males achieve a higher peak bone mass compared to females. This means that bone loss in men is less likely to lead to osteoporosis. Basically, men have a greater bone mass and therefore they can lose more bone before their bones become dangerously thin and develop osteoporosis. Also, one of the standard recommendations to prevent the development of osteoporosis is weight-bearing exercise or weight-bearing activity, and that's because this increases bone mass. Weight-bearing activity is basically activity where you're standing and you're holding up your body weight, and because this increases bone mass, that counters the bone loss that occurs with aging, and that can limit the development of osteoporosis. Let's talk about menopause. As I told you before, menopause accelerates bone loss in women, and the reason for this is because at menopause, when women stop ovulating, a relative estrogen deficiency occurs because less estrogen is made by the ovaries. In the video on bone biology, I talk about how estrogen leads to strengthening of the bones, so an estrogen deficiency leads to weakening of the bones and osteoporosis. So estrogen deficiency leads to increased osteoclast activity. Normally, estrogen suppresses osteoclasts. When a deficiency develops, the osteoclasts become more active. There are a number of reasons for this, but one of them is that there is more expression of the rank ligand in the setting of an estrogen deficiency. The rank ligand is expressed by osteoblasts, and when it's expressed in greater numbers, that leads to more activation of rank and more activation of osteoclast. In the setting of estrogen deficiency, osteoblasts also have been shown to decrease their secretion of osteoprotegerin or OPG. This is the decoy receptor for rank L. Normally it binds rank L and prevents binding to rank, When there's less OPG around, it's easier for rank L to bind rank and stimulate osteoclast. And I review all of this stuff in the video on bone biology. I'm just pointing out to you here that these are the mechanisms underlying the accelerated bone loss in the setting of estrogen deficiency at menopause. Most of the osteoporosis you will see clinically is called senile or postmenopausal osteoporosis. This is thinning of the bones related to the normal loss of bone mass that occurs with aging, like we saw in that graph a few slides ago. In this setting, if you measure the levels of calcium, parathyroid hormone, or alkaline phosphatase, they are all normal, and it's very high yield to know that. Less commonly, you will see osteoporosis that is secondary to either a medication or a clinical problem that the patient has that leads to accelerated bone loss. So it's not just aging or menopause, but there is some other feature of the patient that leads to osteoporosis. So let's talk about those causes now. A classic secondary cause of osteoporosis is glucocorticoid therapy. Glucocorticoids increase bone resorption and reduce bone formation. They've been shown to suppress the synthesis of OPG, the decoy receptor. They've also been shown to increase rank production, that is the receptor found on osteoclast. So many patients who have inflammatory conditions chronically require glucocorticoids for therapy. For example, patients with lupus or rheumatoid arthritis. These patients are at risk for osteoporosis and fractures. Heavy consumption of alcohol, as seen among alcoholics, is associated with osteoporosis. Alcohol is kind of a double whammy. It makes you lose your balance so you can fall easily, and then your bones become weaker, so it's easy to fracture your hip. It's less clear whether moderate alcohol use has effect on bones. There's a lot of conflicting literature about what happens to your bones if you just drink 1 or 2 glasses a day. Smoking is also associated with osteoporosis. It accelerates bone loss. So so-called lifestyle factors like being an alcoholic or smoking can lead to osteoporosis. There are 3 anticonvulsant drugs that can lead to osteoporosis. Those 3 drugs are phenobarbital, phenytoin, and carbamazepine. And I talk about all of these drugs in the neurology section in the video on seizures. These drugs are used to treat seizures and epilepsy, and there's a risk of osteoporosis with long-term therapy. And many patients who have epilepsy need to take these drugs for an extended period of time, and they're at risk for developing osteoporosis. The reason these drugs can cause osteoporosis is because they activate or increase the activity of P450 enzymes in the liver. This leads to an increased breakdown of vitamin D, and there is a relative vitamin D deficiency. As a result, the calcium level will become low, and the parathyroid gland will release more PTH. This will normalize the calcium level, but at the expense of bone loss, and that's why these drugs can lead to osteoporosis. In your textbooks, you'll read that anticoagulants are associated with osteoporosis. The main one that does this is unfractionated heparin. I talk about this in the video on anticoagulants in the hematology section. Unfractionated heparin has been shown to decrease bone formation and increase resorption. This only occurs with long-term use, and in the modern era, we never give this drug for long-term use. So really, this is a non-factor in terms of causing osteoporosis in the modern era. We do sometimes give low molecular weight heparin for long-term use. It's less clear whether this has an effect on bones. So this is mostly a historical thing from decades ago when unfractionated heparin was given for a long term. Thyroid replacement therapy can potentially cause osteoporosis, and to understand this, you need to appreciate that hyperthyroidism leads to osteoporosis and fractures. And this is very easy to remember. You know that hyperthyroidism leads to increased metabolism in many tissue beds, and that includes the bones. So in the bones, there's more bone breakdown when a patient is hyperthyroid. Now, levothyroxine, which is synthetic T4, is used to treat hypothyroidism. And if you give a patient too high a dose, this will cause iatrogenic hyperthyroidism. And if it's mild, it may produce no symptoms, but over time, it can lead to osteoporosis. So what this means is a key test in anyone on therapy with levothyroxine for hypothyroidism is the TSH. If the TSH is normal, it means the patient is euthyroid. However, if the TSH is low, or suppressed, it means the patient is taking too much thyroid replacement and they are at risk for osteoporosis, and you need to lower the dose. And this is a big problem because many elderly postmenopausal women take T4 for hypothyroidism, and if it's not dosed appropriately, it will accelerate bone loss. There are also a number of diseases associated with osteoporosis. So hyperparathyroidism can break down your bones and lead to osteoporosis. Hyperthyroidism, as I just discussed, leads to osteoporosis. Multiple myeloma leads to osteoporosis because the myeloma cells increase osteoclast activity, and this is what results in the classic punched out or lytic bone lesions of multiple myeloma. And then finally, many malabsorption syndromes can lead to poor absorption of calcium and vitamin D. This can also lead to osteoporosis. So people who have celiac disease, Crohn's disease, ulcerative colitis, they all need to take calcium and vitamin D supplements, otherwise they can develop osteoporosis. Let's talk about how you make a diagnosis of osteoporosis. Obviously, we don't routinely biopsy bones to see if the bones are thin, so we need other ways to make a diagnosis. The first way is we say someone has osteoporosis anytime they suffer what's known as a fragility fracture. This is a fall from a standing height or less, not from a major trauma like a motor vehicle accident, where the patient fractures their spine, hip, wrist, humerus, rib, or pelvis. Also, a fragility fracture is if someone has a spontaneous vertebral compression fracture. I'll talk more about this in a minute. But if the patient presents with back pain, does not recall a trauma or a fall, but there's a compression fracture of one of the vertebrae, we say that also is a diagnosis of osteoporosis. Now, hopefully, you can make the diagnosis before patients have a fracture and start them on therapy. And the way you do this is by doing a special test to determine the patient's T-score, and a T-score of minus 2.5 or lower is called osteoporosis. The way a T-score is determined is by a test called a DEXA scan. DEXA stands for Dual Energy X-ray Absorptometry, and it gets its name because two X-rays of different energy levels are aimed at the bones. And when this is done, as shown in this picture on the screen here, the machine can determine a T-score for a patient. The T-score is the patient's bone mineral density determined by a DEXA scan compared to the bone mineral density of a healthy 30-year-old person. If the T-score is negative, it means the patient has a lower bone mineral density compared to a healthy 30-year-old. A normal T-score is minus 1.0 or higher. These are the patients with the least fractures. Osteopenia is a T-score of minus 1 to minus 2.5, and osteoporosis is a T-score of minus 2.5 or lower. These are the patients who have the most fractures. And this is recommended for diagnosis in suspected osteoporosis. It's also recommended for screening in women over 65. If you screen them and determine that they have osteopenia or osteoporosis, you can start them on therapy and potentially prevent fractures. So people with osteoporosis can have fractures anywhere in their body, but there are a couple of classic locations you should know about. The first is the hip. So the hip is a weight-bearing joint, and as I told you earlier, it has lots of trabeculated bone in it that can become thin in osteoporosis, and the hip is easily injured from a fall. So hip fractures are a common problem in elderly patients with osteoporosis. If you go into orthopedic surgery, you will see lots and lots of hip fractures among patients who have osteoporosis. The spine is another classic location for a fracture in osteoporosis, especially the lower thoracic and lumbar spine. This is the portion of our spine that bends and bears a lot of weight from above and requires a lot of twisting. The vertebrae in this area often have what's known as compression fractures. These are fractures that occur slowly over time and result in a shrinking of the vertebrae. Sometimes the patient doesn't even recall trauma, and that's because minor trauma of daily activities is what led to the compression fracture. An important consequence of these compression fractures is loss of height, like this woman shown in the screen here. Many elderly patients, especially elderly women, are very short, and that's because their vertebrae are shrinking from osteoporosis. In addition, the spine can curve forward. This is called kyphosis, and this can also lead to back pain, which is a big problem among patients who have osteoporosis. And that concludes our video on osteoporosis.